Today we have the pleasure of hearing from Dr. Alex Federman, Professor of Medicine and Director of Research for the Division of General Internal Medicine. Dr. Federman received his MD from SUNY Downstate and completed his residency in primary care internal medicine at Montefiore Medical Center. He went on to complete clinical research training through the Harvard Medical School Faculty Development and Fellowship Program in General Internal Medicine and earned a master's in public health from the Harvard School of Public Health. Dr. Federman practices as a general internist, and his research focused on the self-management of complex chronic illnesses by older adults, with a special focus on the impact of cognition, health literacy, and illness-related beliefs. His work also involves evaluation of innovative models of healthcare delivery in ambulatory and acute care settings. He has published widely and been the recipient of numerous awards. Please join me in welcoming Dr. Federman.
Good morning, everybody. Thank you for having me. Happy to be here, and I'm looking forward to sharing some of our work with you. First of all, I have received some consulting fees from a couple of companies, but unrelated to the work that I'm going to be discussing today. So let me begin by telling you a little bit about a patient that is typical of the patients that I see in IMA during my regular practice. This is a 68-year-old woman who came in for a routine visit, and she has asthma, diabetes, high cholesterol, high blood pressure, hypothyroidism, and obesity with a BMI of 40. And on this routine visit, she comes in with complaints of chest tightness and wheezing for the last several weeks. And she's using albuterol many times a day. She takes out a bag and unloads all of these medications in front of me. And one of the first things you might notice, besides the number of medication bottles here, is the absence of an inhaler, controller medication for her asthma, which is the backbone of treatment for people with persistent asthma. Well, it turns out that she's not regularly using her inhaled steroid. And in fact, she doesn't really know the difference between her controller and rescue medications. And moreover, she thinks that when she's not having asthma symptoms, that she doesn't have asthma. In other words, asthma is a disease that is only present when she is having symptoms. And this turns out to be a fairly common belief among asthmatics. Later, at a subsequent visit, she does bring her inhaler, and she demonstrates for me how she uses it. When she puts it in her mouth, all the medicine goes out the side. And many of you have probably seen this. Also, poor inhaler technique is a common problem among many asthmatics. So this patient is not alone. In our own work, we've documented poor adherence with inhaled corticosteroids among many patients. In this study of older adults with asthma in New York and Chicago, we found that only about a third of patients regularly used their inhaled steroid. And it turns out that in another study, we showed that about a quarter of patients with asthma are able to actually distinguish between their controller and their rescue medication. This is work that was done by a medical student, Grace McInerney, who worked with us last year. And in this work, she identified that those patients who are most vulnerable to poor outcomes with asthma were unable to distinguish between the controller and rescue medication. So people who are over 80 and those who had poor English proficiency. And of course, those who didn't distinguish between the controller and rescue medications were more likely to have poor adherence with their controller medications. Other work we've done has demonstrated that the majority of patients, at least among older asthmatics, have very poor inhaler technique. Only about 38% were able to use a meter dose inhaler correctly, and a little more than half could use a dry powdered inhaler like the discus type of inhalers correctly. So these are just some of the many barriers that people with complex chronic diseases face on a daily basis to effectively managing their disease and preventing symptoms and keeping themselves out of the hospital. So today I would like to talk a little bit more about these medically complex patients and how the US healthcare system is trying to respond to the needs of this very complex population, driven primarily by the cost of care that this population generates. And I contend that even though many of these new programs that are coming out are helping to advance our healthcare delivery, they may not actually be going far enough in touching on all of the needs that this population faces. And in fact, we need to develop a more precision medicine approach to addressing the behavioral and health services needs of this complex patient population. So I'm going to then touch on some examples of programs that attempt to be a little bit more patient-tailored and move us a little bit more towards precision healthcare delivery, talk a little bit about their shortcomings, and then wrap up by talking to you about a program that we developed that we hope inches us a little bit further in the right direction. So let me begin first by talking about medical complexity. And so when I'm talking about medical complexity, I'm talking about factors that affect a person's ability to respond to the care that they receive, tolerate that care, access that care, and participate in care in a way that effectively meets their goals and achieves stability with the illness. Now, oftentimes when people think about medical complexity, they're thinking just about the medical conditions themselves. For example, the types of conditions, the number of conditions, maybe the number of medications they're taking or the complexity of the treatments they're receiving. But medical complexity is much more than simply the medical condition that the person has. It involves this whole constellation of factors, sociodemographic factors, the environment, physical factors, neurocognition, psychocognitive issues like affective disorders or their beliefs, and then intrinsic issues like genetics and inflammatory pathways and other issues. Looking at this, many of you might be thinking of the term social determinants of health, which is sort of come onto the scene in a big way over the last 5 to 10 years. And this has really been a great advance in our effort to get towards more precise care delivery for high-risk patients. But what I hope to do is convince you that we need to go beyond the social determinants of health that are currently being discussed, like economic stability and housing and education, food, and other factors, that there's much more to addressing the needs of a medically complex patient than dealing with the medical issues and the social determinants of health. And why is this an important issue? Because we're seeing a growth in the population of the medically complex patients. Much of this is driven by the aging of the US population. I'm sure you've all seen a curve like this. And with this growth in aging, we're seeing greater prevalence of many of the factors that come along with aging, like cognitive decline, so a higher prevalence of people with cognitive impairment. As you know, as people get older, cognition declines. And then we also see an increase in the prevalence of chronic conditions. And over the years, we've seen increases in hypertension, obesity, asthma, diabetes, and so forth. And then this, of course, brings increases in the prevalence of multimorbidity, approximately 10% increase, whether you define multimorbidity as 2, 3, or 4 or more conditions. And multimorbidity, of course, brings greater use of prescription medications. And so the prevalence of polypharmacy has also grown over the last couple of decades. Now, if you look at that constellation of factors in the context of a sociodemographic lens, then it's sort of a crucible for worse outcomes. We've seen over the last several decades a shrinking of the middle class and growth of the lower income population. And healthcare costs for individuals are rising. This slide shows the growth of wages in the red line and the growth in insurance premiums and deductibles in the blue and green lines, which greatly outpace earnings. And so that puts a tremendous financial pressure on all these people who, at the same time, are finding themselves developing more and more chronic illnesses and costs that accompany them. So that's, I think, for me, is a fairly gloomy picture, but on the upside is that there has been a response to this, again, driven by the large increase in healthcare costs and those pressures that our country is facing. I think you've probably all seen figures like the one on the right. But that has created great new opportunities for all of us who care about really getting the health care to patients that they need. By creating new types of programs and incentives to really align care delivery with the needs of patients. So we've seen the emergence of programs like the hospital readmissions reduction program, shared savings models, including accountable care organizations, delivery system reform for Medicaid or DSRIP, and risk contracting between healthcare providers and insurers. And in the context of these programs or incentives, we're seeing sort of an explosion of new programs to help those higher risk patients, like medication reconciliation, medication therapy management, chronic disease management programs, different efforts to reduce preventable hospital readmissions, and then care transitions programs, among a variety of others. And these programs are starting to have an impact, fortunately. So this slide shows heart failure readmissions, and the arrow shows when the hospital readmission risk program was implemented, and you can see the curve starts to bend down. And in the first couple of years of that program, there was a 2% decline in readmissions and considerable savings that came along with that. Medicare ACOs, as of 2018, were saving $73 per beneficiary, and that at first may not sound like a lot of money, but when you consider the growth in ACO participation, upwards of 33 million people by 2018, that adds up to a lot of money. So nearly $2 billion of savings in 2018 from ACOs. Now that's actually sort of just hardly constitutes a drop in the bucket when you consider that Medicare costs are annually in the range of $700 to $750 billion, but at least it's moving in the right direction and suggests that many of the programs that are being implemented are having an effect. Here's another program. This is called Independence at Home. It was a demonstration program implemented by CMS a number of years ago. And what that does is it provides opportunities for shared savings for programs that deliver health care in the home for high-risk patients. And this program has been enormously successful. You can see the last column, the improvement in reductions in preventable hospitalizations for patients. And in the last year of the program, they had reduced preventable readmissions by about 14%. So that's been a great advance. Now, so there are a variety of incentives out there for getting greater alignment with care delivery with the specific needs of patients, and we've seen some encouraging results. But I think you would probably agree with me that there's a long way to go. And why is it that we have a long way to go? Well, first of all, there's a very steep learning curve to understanding how these programs work and adopting them, and these adaptations take a long time. There are many different types of incentive and payment programs and approaches to working with complex populations, and so that makes learning a little bit difficult. There's a lot of comparisons of apples and oranges. There are many regulatory barriers and other logistical challenges for adoption and implementation. But I want to focus today on this last point, which is that programs may not be going far enough in identifying and addressing the barriers to health outcomes. In other words, they may not be taking making enough of an effort to really pinpoint where in this constellation of issues patients really need particular support. There was a report that came out from the National Academy of Medicine a couple of years ago that backs up my point here. And in this report, which was focused on care delivery programs for high needs patients, they reviewed some of the most popular and prominent programs across the United States for dealing with high needs populations. And they found that fewer than half of these programs targeted social and behavioral risk factors. You can see those are the ones that have an asterisk. And they pointed that out as a major deficit in the ability of these programs to achieve their objectives. Over the last 8 or so years of research in our group in the Division of General Medicine, we've looked at various facets of all of these different domains. And that work has very much informed our perspective on strategies towards trying to support these medically complex, high-risk patients. So what I'd like to do now is talk somewhat superficially about the work we've done that touches on these different domains, just to give you a little bit of a feel of the types of factors that we're looking at and the breadth of issues that these medically complex patients face. So to begin with, looking at this, the medical domain of this figure, this was work that was done by a project manager in our group, Emily Goodman, that looked at patterns of medication adherence across multiple conditions in older asthmatics with multimorbidity. And what she found was that adherence to one therapeutic class of medications did not necessarily predict adherence to another class. So, for example, people with hypertension who were very adherent to their hypertension medications were also quite adherent to their high cholesterol medications, but adherence to hypertension medications did not predict good adherence to their asthma medications. And what we took away from these findings was that if you're thinking about trying to promote adherence in a group of patients that have multiple conditions, it's not enough to take a one-size-fits-all approach to promoting adherence, as most adherence support interventions do. Rather, you really need to look very specifically at the patterns of adherence for each particular medication that they're using, at least those of significance. We've done a fair amount of work with health literacy. And in this particular study, we reported that low health literacy was associated with poor adherence to controller inhalers, as well as with inhaler technique. And having low English proficiency is a risk factor also for having low health literacy. But even if you control for health literacy, limited English proficiency in and of itself is a risk factor for poor outcomes with asthma, such as poor asthma-related quality of life and poor medication adherence. Looking in the domain of environmental factors, Paula Bussi and Juan Wisniewski a few years ago looked at the prevalence of allergen sensitivity across a different age range, different age groups, and found that there was indeed different sensitivities to different allergies, to different allergens. And this kind of opens the door to the possibility of more precise strategies for environmental remediation for patients in these different groups. Physical impairment is an issue for many patients, and that can get in the way of self-management. And in this particular study done by a medical student, Eric Woods, working with us a few years ago, he found that those with more severe asthma control were more likely to have physical impairment, and in turn, that physical impairment was a risk factor for difficulty using inhaler medications, and subsequently for worse control of their disease. We've also looked at cognitive impairment and found that, people with more advanced asthma are more likely to have cognitive impairment, and that impairments of executive functioning or fluid cognitive abilities are detrimental to people's ability to follow prescribed self-management behaviors, including using their inhalers correctly. Medication organization is another reflection of cognitive impairment, and in another set of studies, we identified the patterns in which people organize their medications and found that those individuals who are able to integrate their use of medications into a daily routine were much more likely to be adherent to their medications than others. In particular, those folks who kept their medications in the bathroom, actually, as opposed to on the bedstand or in the kitchen or in their purse, were far more adherent to their medications than those who did not. Moving on to the psychocognitive domain, we've done a fair amount of work looking at the beliefs that people have towards their illnesses and the treatments for their illnesses. And those who have adopted maladaptive beliefs towards those issues are less likely to use their medications regularly. So for instance, those who feel that they don't have asthma unless they're actually having symptoms are more likely to use their controller medications regularly. And finally, we're doing some work in depression and found that people who have depression are also having difficulty following prescribed self-management behaviors and having poor control of their asthma. And fortunately, we were about to start a new study that is going to take us into greater detail on this subject. So this is a lot of different factors that affect how people manage their disease and their actual control of their asthma. And many of these factors have strong associations, some have milder associations, but few of them really actually explain most of the behaviors that we're seeing. And this figure sort of demonstrates this. This is a figure from what's called a structural equation model, and this is a statistical technique that often gets applied to observational data and seeks to explain the different pathways through which an exposure variable, in this case health literacy, impacts an outcome variable, here medication adherence. And one of the first things I hope you'll notice here is that health literacy explains only 12% of the variation in medication adherence. And the second important takeaway from this figure is that much of the impact of health literacy on adherence is not through health literacy itself, but through illness beliefs. So through patients' concerns about their medications and their beliefs about the necessity for those medications. So if we are designing an intervention to try to improve medication adherence, it's not enough to say, okay, we're going to just redesign our educational materials so they can be understood and adopted by a low health literacy population of patients. We really need to be considering this entire milieu of factors that are impacting medication adherence. So I hope that I've sort of given you a sense of the importance of this constellation of factors that affect medical complexity and medical outcomes. Once we sort of developed that appreciation, we started to look for how interventions out there were addressing these. And to our surprise, we found that we couldn't find any interventions that really tried to pinpoint where on this wheel patients were having problems in targeting them. There are many interventions out there that touch on various aspects of them, but none that really try to be comprehensive in their approach. So I'm going to talk a little bit about some representative interventions, just to give you a little bit of a feel for that, and then move on to talk about the intervention that we developed. So I'm going to begin with this study, which was a randomized controlled trial of self-regulation for older adults with asthma. And this was done with folks in the Ann Arbor area who had moderate or severe persistent asthma. And the intervention was nurse-led. There were 6 sessions, half of which were in person, the other half were in phone. And it began with generalized education about asthma, so non-targeted information about the basics of asthma and how it's treated. And then there was some goal setting around what the patients wanted to achieve with their asthma. And then the tailored aspect of this intervention really focused around what barriers the patients thought they faced with respect to achieving those goals. And by and large, this intervention touched on these 3 top areas on the figure: asthma itself, a few social determinants of health, and some environmental factors. So the intervention had a non-significant benefit for asthma control, and this is partly, there was a benefit. It was probably underpowered to see a statistical difference, but there were some hopeful findings here. There was limited improvement in asthma-related quality of life and a small difference in hospital events. There were 4 hospitalizations in the control group and none in the intervention group, but there were no differences in emergency department visits. The next study was an intervention for COPD patients. So these were COPD patients who were in the hospital, and the intervention was, again, nurse-led. It involved connecting with the patients in the hospital, providing them transition services, and then 3 months of self-management support, which focused very broadly on education around medication use, exacerbation management, smoking cessation. And then they worked to facilitate patients' access to different community-based services. And they touched here on a variety of factors. And on the psychocognitive domain, there was a special emphasis on depression in these patients. Unfortunately, this was a negative study. This is the main outcome, which was hospitalization. And patients in the intervention arm were actually more likely to end up in the hospital than those in usual care. And for their secondary outcomes, there were no significant differences. For example, their symptoms and level of activity. So this was a little bit of a surprise, and the authors of the study have some thoughts about why it was that they saw such poor outcomes, but it was a major disappointment for many who were interested in this approach to supporting patients. The last study I wanted to mention is one that's done a little bit better. This is a study that came out of a group at Penn. This was a community health worker-driven intervention that targeted low-income, publicly insured and uninsured patients with 2 or more chronic diseases. So this was not disease-focused, it was medical complexity-focused. And the community health worker worked with the patient to identify their goals. So again, a goal-oriented, patient-set, goal-oriented intervention with problem solving around those goals, and support to meet those goals on an ongoing basis over a 6-month period of time. And it touched on a few more of these domains than the previous studies did. Again, also addressing depression as a major barrier to disease control. And this study did a little bit better than the previous ones. There was lower risk of readmissions, a 17% reduction in readmissions. But there was there was a reduction in hospitalizations, although it was a non-significant reduction. So these are representative studies. They, don't even touch the enormous volume of literature out there on different interventions for patients with complex medical conditions. But what's similar about them is that they approach and they take a patient-tailored approach to addressing the needs of medical complexity or medically complex patients, but they're not comprehensive in their approach to meeting the needs of those particular patients. And we recognize that as a real shortcoming in the literature. And so we sought to design an intervention that would get us a little bit closer to being able to take a pinpoint strategy to identifying the needs of patients and addressing those needs. So we developed an intervention which we called Supporting Asthma Self-Management Behaviors in Aging Adults, or SAMBA, and got funding from PCORI to do that development work and then conduct a randomized trial to test it. The objectives of this intervention were to achieve better health outcomes and quality of life for a medically complex population of older adults with asthma. And specifically to systematically identify the barriers to self-management and poor disease outcomes that patients face across these different domains, and then specifically target each of those barriers that we were able to identify wherever possible with evidence-based strategies, and if evidence-based strategies were not available, then using the best information that we could get from stakeholders about how to deal with those particular problems. We also wanted to design this as a sustainable approach, and so we thought about this, the current context of healthcare delivery, where there's greater investment in care management, population health, and particularly in the hiring of layperson navigators, care coaches, and community health workers. So we designed this as a strategy that could be adopted by any program that was using community health workers or care coaches in their care delivery. So in order to develop this, we first gleaned the literature to identify as many barriers as we could, not only to asthma self-management, but to management of other chronic diseases, figuring that a lot of it applies to any condition, regardless of the condition. And then we also looked for interventions that we could tag to each of the barriers that we were able to identify. We then did patient and caregiver focus groups and held focus groups with other stakeholders, including clinicians or primary care physicians, pulmonologists, allergists, folks from community-based organizations who work with medically complex patients, people in the Department of Health, and payers as well, to get their perspectives on these issues. This slide shows some of the takeaway from these, at least from our patient and caregiver focus groups, where we were able to identify a few of the gaps, a few barriers and strategies that hadn't appeared in the research literature. So for example, lots of patients talked about challenges getting their, actually picking up their prescriptions because they had difficulty leaving the home and they were enrolled in a mail order service. Lots of patients talked about an inability to do anything about their environment, even though they had mold or pests in the home. They felt that there were no resources available to them. Sometimes patients had symptoms and they weren't sure whether they were asthma or whether it was a problem with their heart failure or some other condition. So there was confusion among many patients about what they were actually treating or trying to self-treat. And then a lot of patients had problems actually coping with their symptoms, and sometimes would do things like just try to ignore it until it got so bad that they had to call their doctor and go straight to the emergency department instead of trying to treat it early on or seek help earlier on. So we took that information and everything that we gleaned from the literature and we created a screening tool that we could use to systematically identify the barriers to effective self-management and asthma control in this population. What we wanted to be able to do is rapidly and systematically identify these barriers and then link those barriers to specific actions. And the screener that we created had 68 questions and took upwards of about an hour to complete. These are some of the topics that were included on the screener. The coach or community health worker would review the patient's medications, determine whether they're actually taking those medications, review their inhaler technique, ask them about their beliefs about asthma or their medications, their use of complementary and alternative medications, self-monitoring practices like the use of a peak flow meter, how they prioritize asthma amongst all their other chronic diseases and manage their medications in that context, how they organize their medications, how cost affects their health care, what's triggering their asthma and environmental exposure, depression, cognitive impairment, and a variety of other topics. So we had two intervention arms in this trial, one in which the intervention was delivered in the home by a community health worker, and the other where it was delivered in the clinic setting with a healthcare coach. And whether it was at home or in the clinic, the activities of these folks were basically the same. They reconciled the medications with the patients, did the assessment of asthma control, screened for barriers to asthma control, and then talked with the patients about how they should try to address each of these barriers. And they had a menu of options from which they could select, or they could come up with a solution, a de novo solution with the patient. And then ultimately we wanted these coaches to be able to communicate with the physicians about what was going on with the patients. But as I'll mention a little later on, there were some challenges to that. These care coaches, as I mentioned before, were lay folks, so non-professionals, in contrast to many of the other studies that I showed you, which involved often nurses or other professionals. We gave them basic training in asthma physiology and management. They basically came to us already with some motivational interviewing skills. We emphasized skills for communicating effectively with low literacy populations. And we sort of beefed up or worked to beef up their ability to connect community-based resources and institutional resources to meet the needs of patients. And then we had monthly meetings to review cases with all these coaches. We bring all the coaches together from the different participating organizations and review cases and then offer continuing education. And that turned out to really be an essential piece of this intervention, not only to get them to be able to master the way in which they deliver this intervention, but to get them to really have skin in the game by feeling that they're developing their own skills as they participate. So I'll go now to the results of this trial. We recruited people who were 60 and older who had uncontrolled moderate to severe persistent asthma, and we recruited patients from Mount Sinai and from the Institute for Family Health. This is our consort table. I'll just point out a few highlights. We randomized 406 patients to one of three arms. As I mentioned, we had patients receiving the intervention at home or in the clinic, and we compared them to usual care. For our primary analyses, we aggregated the data from these two intervention arms. Importantly, we had quite a bit of drop-off in this study. About a third of patients dropped out by the 12-month mark across all arms of the study. And I'm going to talk a little bit about that as well towards the end. But let me jump to the main findings. So the overall, patients had improvement in their asthma control, significant improvement in their asthma control, and in their asthma-related quality of life. And the number needed to treat to achieve a minimal clinically important difference in asthma control and quality of life at 6 months was 9 and 5, respectively. And at 12 months, those numbers bumped up to 30 and 14, and we think that was largely because of steady attrition. But by and large, these are, if I must say so myself, these are very good numbers with respect to number needed to treat in comparison to other studies for asthma self-management interventions. We also saw improvements in medication adherence, about a 30% improvement in medication adherence, a 15% improvement in inhaler technique, and we saw a drop in emergency department visits, 6.2% for patients in the intervention arms versus 12.7% for patients in the usual care control group. So we're very encouraged by these results. Everything goes in the right direction. We had improvements in self-management behaviors and improvements in patient outcomes. But we also recognize that in many respects, these are not overwhelming results, and that there's a long ways to go, as we saw with some of these other programs that have arisen in the last few years. So we brought all our group together at the end of the study to kind of review the process, all of our stakeholders, and try to figure out where we need to focus next. And we identified 4 areas where we feel that there's opportunities for improvement. And we think that these lessons also apply to other interventions as well that aim to support medically complex patients. So the first one was in closing the communication gap. If you think about a community health worker, this is somebody who gets to see a person in their home, in their real environment, and all the different issues that that patient is facing. So maybe they've got 30 different medications, many of which are expired, and they're all sitting out on their nightstand. That is really valuable information for us clinicians to have. But there are serious barriers to having communication between somebody who is working with an outside organization, getting past that HIPAA firewall that is designed to protect patient information. And we feel that this type of intervention that employs individuals from the community to support patients are really not going to hit their maximal impact until we can optimize communication between these folks and the clinical care team. The other is with promoting engagement and retention. So we were not alone in our study in having difficulty engaging patients from the outset in the intervention or in holding them, keeping them in the study. These are folks that have a lot going on in their lives, and even though they are actively having asthma symptoms, they're distressed about paying their bills and dealing with other issues. And so spending an hour here and there with community health work is not always near the top of their priority list. And so the messaging, the ways of demonstrating value to these patients is still a work in progress. What we did find is that when the coach demonstrated value to the patient in a way that was somewhat unrelated to our goals of improving asthma care, there was greater buy-in by the patient. For example, if the patient went to the pharmacy to pick up if the community health worker went to the patient's pharmacy to pick up all of their newly prescribed medications, whether it was an asthma medication or not, really helped get that patient engaged in the process. The other lies with integrating external resources. So with all of these different problems, a health system like ours doesn't necessarily have the resources to deal with housing issues or food scarcity or other related problems that patients may face. But those resources, many of those resources are available to patients out in the community, and we just need to have do a better job of being able to tap those resources and getting them to patients in order to help them achieve better health outcomes. And finally, we need to do a better job of trying to identify patients that will do well in these types of programs. These are resource-intensive programs, and they're not suitable for every patient, but it's difficult to identify the right patients for that. And along those lines, we did a post hoc analysis to try to identify which patients did best with our intervention, and we found that those with poor asthma control, airway obstruction, lower incomes, and poor medication adherence did better with the intervention. Interestingly, those with prior emergency department visits did not necessarily do better with the intervention, and that sort of flies in the face with the typical strategy that programs in healthcare institutions take for identifying patients who might benefit or where they want to apply those resources. So we look at patients who have a previous hospitalization in an emergency department, and we go and target those patients for an intensive program. So in this case, that particular market didn't quite pan out. So in moving towards a more precision-oriented, a more precise take on identifying the barriers to achieving better outcomes for medically complex patients, we think that this intervention is helping us move a little bit in that direction. And fortunately, we're going to have some opportunity to try to apply the lessons learned. We recently got funding from the NIH to adapt this model that we developed for asthma to people with COPD with an R34 grant that we recently started. And with that funding, we're focusing more on dealing with this issue of closing the communication gap. And here we're going to have the coaches actually come to the appointments with clinicians. We're working on promoting engagement and retention by applying some strategies that Mary Tonetti has developed, and doing a better job of integrating external resources into care delivery for these patients. We don't quite have the bandwidth on this particular study to work on identifying patients who are going to do best for this, but in a separate set of work that we're doing with Lily Chan and Girish Narkani from nephrology, we've been using machine learning techniques to identify patients with cognitive impairment in primary care settings using data from the electronic medical record. And we recently just got a fundable score in R01 that's going to allow us to develop those techniques in a rigorous way. And we think that we're going to be able to apply that methodology to do a better job for identifying high-risk patients for this and other types of interventions. So in conclusion, I hope that I've given you a sense that if we want to really do a better job of improving outcomes for medically complex patients, we have to take a pinpoint strategy for identifying where their problems lie across the spectrum of issues. And that it's doable. There's a lot of work to be done, but hopefully we're moving in the right direction. So I want to thank my colleagues and thank you for your time.
Dr. Alex, for that really illuminating discussion on a very complex topic. There's some questions? Yeah.
Thank you. Really, really interesting, amazing body of work. I'm curious because you talked about the community settings, the different organizations or resources that are out there, and the challenge of integrating that in within the healthcare setting and the patients. How has DISRIP been able to help with that component, and what happens moving forward?
I think that the verdict is out on that. So there have been some lessons learned from DISRIP that we're able to apply, but we've been in trying to advance this particular model. We were talking with the DISRIP folks, and it was very difficult to get much interest in adoption of any of these strategies. And I think that this is one of the challenges that we face in doing healthcare delivery research within a large healthcare system. When there's an initiative like DISRIP, there's a tremendous pressure to move things along very quickly. And so there's a tendency to rapidly put together a plan of action and move it forward. And basically little to no room in that rubric for the kind of slower methodological approach we take with research, or for even much of the adoption of the best practices that come out of the work that we develop. And so, unfortunately, there's a little bit of parallel activity going on with these initiatives kind of moving at their own pace and ours, and we're trying to learn from the real world experience of DISRIP, but it's difficult to kind of integrate the two. Did that answer your question?
Yeah, to me, the challenge in this is really figuring out how to best really integrate them so they can harmonize and work together.
Yeah.
And what are some of the lessons that have been learned that you can utilize to change that? Not necessarily for DISRIP itself, but for existing community resources. And out of the University of Chicago, they created these incredible softwares. What can how do we harness that work to really help integrate it and move forward?
Yeah. Well, there's, from our part, what we've done was we've gone and spoken to the leaders of all these programs. So folks in DISRIP, for example, with this R34 funded project for COPD, we are talking to everybody within the institution who is running a COPD program. So there's something going on in IMA, there's something going on in Pop Health around COPD, and there's work going on in the Respiratory Institute. And so we go and we talk to them about their individual lessons learned, and we're trying to align resources as much as possible. So it's, it's hard to say that there's any sort of big picture lessons to learn. There's lots of little, this works, that works. That's kind of what the general takeaway that I've had from this process.
So in those programs where you had some demonstrable benefit, how much follow-up do you need to maintain that benefit? Do you send people out to pick up medicines year after year?
Yeah.
Or other things?
Yeah. So very few studies go beyond 12 months. But there are a range of follow-up periods. Some go a month, some go 3, 6, 12. It's very clear that the longer you're with the patient, the better the outcome. And I think I hear your point that, do we need to be providing this, these kind of support to patients forever? And the answer is perhaps that for some patients, yes. And for some patients, it's enough to sort of just get them into a habit and get some of the infrastructure set up, and then periodically check in. And this gets back to the point of being precise about the needs of patients and learning along the way about what patients need. So there's no stock answer to that. But I think in the long run, some patients are going to need more intensive, regular follow-up for a long period of time, and others won't.
Last question about.
First of all, congratulations on taking on such a tough population and problem. But the second part of my hoarse throat is that unknown to most of the doctors in this audience and throughout the nation, a high percentage of older, mentally intact older people decide not to take selective medications on a daily basis. They don't like the way they feel.
Right.
The doctor doesn't ask and the patient doesn't volunteer.
Correct.
So that really complicates your methodology.
Yeah, that's exactly right. And there's no easy solution to that. So in this intervention, our screening approach tried to get at the reasons why patients weren't taking their medication. That includes, were they having problematic side effects? And one of the actions that coach had as a possible menu of options was to try to communicate back to the clinician that, hey, this patient is not taking this medication because they're having these particular side effects, or they just don't like how they feel on this medication. In some cases, that appears to have worked, mostly when the coach accompanied the patient to an appointment with the doctor and was able to help the patient articulate that concern. And that's why we are going to try in this next iteration of this intervention to have the coach attend the visit with the physician, with the patient, at least once to convey the patient's major concerns and barriers.
In the interest of time, I think we'll just close out from here. But if you have any further questions, please feel free to come forward. Thanks very much.
Thanks.